All right. Hello, everyone. Mrs. Ignacio here, and I have a graduate, Lakeisha Smith, and we're going to be talking about safety, lifting, moving, positioning patients, hygiene care, personal care, skin care, prevention of pressure ulcers, patient environment, and safety. So those are the topics that we're going to be kind of walking through for this session. All right, so let me ask you something, Lakeisha. When you're working with a patient, maybe an elderly patient, and they have had fractures before, and the patient is frail, they've got a history of falls. What are some of the things you would do to keep them safe?
So I would make sure the lining is good in their environment, make sure there's no loose rugs or anything also um throughout the home, no cords or anything. I'll make sure that the person continues to use an assistive device if that's required, if the doctor ordered that. Um,
Okay. Okay, so yeah, those are great things for safety. Okay, great things for safety. Now, what about if you're in a hospital setting, you're working with this patient and they couldn't get out of bed and you had to remake the bed. What are some of the things that you would do to keep yourself safe?
So I would raise the bed up to my level was easy. I make sure if I'm changing her bed, I make sure that the one side of the rail that I'm turning her on, the side that I'm turning her to is up. I'll make sure that when I leave, the call bill is by her, the bed is at the lowest position, and just make sure that she has everything that she needs.
Okay, excellent. Okay, so definitely. So you're keeping your patient safe. At first, keeping the bed in the lowest position, the call bell is within reach. The two top side rails are up, and even if you're repositioning the patient, when you're actually changing this occupied bed, you're going to make sure that you put the bed now at a good working height so you can protect yourself and protect your back and to prevent any injuries to yourself. So that's really good. That's really safe. Now, you've already made the patient's bed. Now you're going into maybe performing hygiene care. So, what are some of the things you need to consider when you're working with a frail older adult and hygiene care?
So I would look at with hygiene care, I just look at the things that they're able to do. I'll make sure that they um I make sure I let them do it. Like if they're able to wash their face or, pick out the clothes or um wash different parts of that area, then I will do it. And then also just depending on like if they're on bleeding precautions and things like that, the toothbrushes to use or the different razors that I would choose instead of using the hand razor. I use a electric razor, just things like that.
Okay, so that's great. So you mentioned something that's important, Lakeisha. So you mentioned if they're bleeding or if they're on bleeding precautions, you wouldn't use a straight edge razor. You would use an electric razor because there's less of a risk to the patient. Because this bleeding precaution patient can actually, a small cut can actually, maybe hemorrhage and cause them to lose a lot of blood. Okay, so that's really good points you brought up. What about the temperature of the water for your elderly, frail patient?
I know they say test the temperature with like this is old school. With the your wrist, like the inside wrist, but you know what, Miss Inacio, I don't know the temperature, like per se, like if they say if
Okay.
it's 37.6 or Celsius, I don't know exactly the temperature.
I don't know exactly the temperature either. 110 comes to mind. I'm gonna have to look that up real quick. But what you're saying is true as far as testing it with your wrist. That's a good thing to do because you don't want to use the palm of your hand or your fingertips because those are kind of, tougher and not as sensitive. So your wrist is going to be the thing that you want to use to make sure that the water is warm and not hot. So that is going to be important. And you want to make sure that the room is a good temperature also, that the room is warm, and you only uncover the parts of the patient that you need to. So we're not going to completely, strip our patients. We're going to give them some dignity, protect them, and just uncover the parts as we're washing them and drying them segment by segment. Only uncover what we need to. And I'm going to have to get back to you on the temperature. 110 comes to mind, but I'm not 100% sure about that part of it. The other thing to remember is with this elderly patient that they have, lost a lot of their muscle. They have lost some subcutaneous tissue because of the normal, changes that take place with aging. They've lost some collagen and elastin, so their skin is less firm, less supple. So that puts them at risk for skin tears, right? So that's just one of the things that as we age, our muscle cells are lost, they're replaced by fat, and this can lead to the loss of muscle strength in this patient. Okay, so let's talk about a patient that we are transferring, and the patient has a weak side. So if we're going to be transferring this patient from the bed to a wheelchair, what are some of the things that we need to keep in mind?
We're gonna place their assistive devices on the stronger side. So if they have a wheelchair, we'll place them. If their left side's weak, we'll place it on the right side. Um, um, the bed, once again.
Mm-hmm.
Um, let me see. We're gonna if they have to stand or whatnot, we'll use a gait belt.
Mm-hmm. Okay, yes.
Helping them stand or whatnot if they have a weak side. Also, let me see. I think that's all that's coming to mind right now.
Okay, so that's good. Those are great things. Okay, and I'm while you were saying that, I was looking it up, and I'm seeing that around no more than 110. So 110 might be a little bit too even warm. So they're saying maybe like, 105 or so. But yes, nothing more than you know 110 degrees. And of course, one of the things you could do is you can let the patient test it. If you put the washcloth in, you can let the patient test that water that way, and that could be a good kind of gauge to make sure that you don't burn the patient. Okay. And so you mentioned a lot of great things also when you were, getting that patient ready for transfer. And so if you have a patient that has, for example, like you said, the left-sided weakness and their gait is unsteady, we're going to place that wheelchair on the right side of the client because we want them to be able to pivot. So when we put the wheelchair, we have to make sure that we place it on the patient's stronger side because that will help them with the ease of transfer. Okay, so great, great, great information there. Let's talk about your patient who is a same frail elderly patient, and we are working with them to build up their strength and their muscle tone. Maybe they're in physical therapy. What are some of the nursing interventions that you would implement after the patient comes back from physical therapy?
I would like you're trying to say assess for pain and give them pain medicine if needed and things like that.
Okay, yes, that's a great thing, right? Because after physical therapy, they're probably going to be in pain. They may be tired. What else do you think they may be experiencing after physical therapy?
Um, I don't know, Miss Ignacio. I'm trying to.
Okay, no, that's okay. So if the patient comes back from physical therapy, you were right to address their pain. You were also right to talk about, assessing the patient to see where they are. We also probably want to rehydrate them because that's going to be something that's really important because if they were kind of working out, they may be sweaty, they may be diaphoretic, they may be like really physically exerted. So we want to push fluids as long as it's not contraindicated so they can help cool themselves down and rehydrate their bodies, okay? And so when we think about diaphoresis, we know that that's sweating that cools the body through evaporative cooling, and drinking fluids is going to be a great way to help this patient become rehydrated, okay? All right, so when you are transferring the patient, another thing that's important is that we didn't mention is to make sure that the wheelchair is locked, okay? To make sure that the wheelchair, the brakes are on the wheelchair, the brakes are on the bed. That's always a good thing to do before you actually transfer your patients. Make sure that all those safety measures, you know, locking the wheelchair, locking the bed is already done, okay? So what, Lakeisha, is the pressure sore assessment tool or the skin assessment tool that we use?
Um, I'm sorry. Can you repeat it?
Yes, the pressure assessment skin, I'm sorry, the pressure sore risk predictor that we use.
Um, I don't-
Um,
like the staging?
Not
No.
necessarily the staging, but the actual scale that we use. And we do it, we perform this assessment using this scale every shift for every patient. It starts with a B.
Starts with a V.
Yes, the Braden scale, the Braden
I
scale.
was gonna say that. Okay.
I'm
No,
sorry, I didn't give you enough time.
I wasn't really gonna say that, but I was thinking that in my head, and I didn't want to say it out loud if it was wrong.
Yeah, well, that's okay. That's totally fine. Okay, so the Braden scale. So let me just mention the Braden scale real quick. I'm going to share my screen just to bring up the Braden scale. And so the Braden scale should be done every shift for every patient, and it tells us, you know, what is their risk of actually developing a pressure ulcer. And so the higher the score, actually, no, the lower the score. I have to double check because sometimes, you know, when you get these things, it tells you, okay, let's see. Do you see the Braden scale now?
I do.
Okay, perfect. So, okay, so for this one, the lower the score, the higher the risk of actually developing a pressure ulcer. Okay, so that's going to be important. And so we're thinking about moisture. If this patient is immobile, do they have any alterations in sensory perception? Can they actually know if they're wet or not? Because that's going to be a big thing. Because if they can tell you that they are wet, then or moist, then that means, you know, okay, they're alert to it, but then you can go in and change them because sometimes patients are not aware of what's going on if they're wet or if they're dry or if they're incontinent. Also, their level of activity comes into play. That's going to be important. Their nutrition. We know that, you know, if they're low on protein, if they're malnutrition, they don't have enough zinc, vitamin A, C, and E, that also can affect their ability to have their skin to be healthy. So they're already at a place where they can have compromised skin integrity. But the scale that we use is going to be the Braden scale, and that is used to predict pressure ulcer risk. Okay, welcome, Erica. How are you doing today?
I'm good. How are you?
Great, thanks. All right, so we have Lakeisha here. We're just kind of going down the list, and I am recording, and so we're going to be posting this afterwards. So we've just finished talking about the Braden scale that we use for pressure ulcer sore risk, and so the lower the scale, the lower the number, the greater the risks the patient has for developing these pressure ulcers. Okay, so let's talk about the different stages of pressure ulcers. Okay, so the what comes to mind, Lakeisha, when we talk about the stages of pressure ulcers?
Like the different how intact your skin is to me. So like um there's about I think 5 stages, And one is the lightest stage, I guess, where it's just beginning, where it's reddened, the skin is still intact.
Mm-hmm.
And so you just kind of want to continue to turn them every 2 hours and monitor that spot. And the second one, it's like a shadow opening. It's like a little, it's a skin tear. Okay. It's not deep or anything. It's really just like a scratch or whatnot is what I remember it as. And
Okay.
then oh, go ahead.
Go ahead. You're doing great.
Okay, then you're what just apply any that the doctor tells you to apply, or cover it and do the daily treatments. And the third one is kind of a little deeper one. And I just remember this as, you're not seeing any like whiteness or tendons or bone or anything. It's just gosh, what is it?
Okay, you're doing great. You're doing great. I'm going to share a picture to kind of help you with this. Okay,
Oh,
so kind of help jog your memory for these different stages of pressure ulcers. Okay. Um, okay, so when we think about the development of pressure ulcers, you did great. You talked about stage one. And so you mentioned, it's going to be maybe an area of redness or pinkness, and that spot is going to be non-blanchable, erythema. So non-blanchable meaning when I press it with my fingertips, it doesn't change color. It stays red or is pink color, and that's what we're talking about with the erythema. Now, the skin is still intact. Once the skin becomes broken, then, like you said, it's kind of like a scratch. That's going to be your stage two. And so it's a partial thickness loss. And I am sharing my screen. Can you see the different pictures here of the stages?
yes, we can.
Okay, perfect. Okay, and then stage three, that's going to be full thickness, and we have subcutaneous damage. So this goes down to the deeper layers of the skin. And then stage four, we have necrosis. So there's going to be some black tissue. There's going to be damage to the muscle and possibly down to the bone. And this is going to be extremely painful. Okay, when we think about this. Okay. So you did a great job giving us that description. And so when we think about stage four, it's full thickness skin loss, extensive tissue necrosis or damage to the muscle, the bone, the supporting structures. Okay, so that's really, really important to understand. All right, so let's talk about the age-related changes with our skin. Something that happens as we get older is that we lose collagen, we lose elastin, and that actually makes the skin more fragile and slower to heal. And so, again, we have to make sure that we are very careful when we're handling our geriatric patients because of the risk of those skin tears, because of the loss of collagen fibers, because the skin is more fragile, because it's slower to heal. Okay. So let's talk about restraints. And this could be for Lakeisha or Erica. What would be a reason for a patient requiring restraints?
If they are coming out of anesthesia and trying to rip out um, any kind of tubes or IV or anything.
Okay, yes, that's an excellent example, Erica. I love that. Okay. Lakeisha, do you have any other ideas as to why a patient may be placed in a restraint or a protective device?
I was gonna say if they were just being really aggressive and trying to hit or hurt themselves.
Okay, yes. Okay, yeah. So both of you described some circumstances in which a patient would actually be placed in a restraint or protective device. Remember, these restraints, we're going to start with least restrictive and then to most restrictive, right? We always want to start on the lower end. We don't automatically escalate. And so as long as the patient is displaying these behaviors, then the restraint is going to be required. Restraints are good for 24 hours. It has to be by a doctor's order. If the patient has a restraint, we have to take off the restraint every 2 hours to assess the skin, assess the pulses, look out for any signs of numbness, tingling, or paralysis. We also want to check the capillary refill, right? Those are part of our neurovascular checks. The restraint must be placed on a part of the bed that does not move. The restraint must also be placed onto that part of the bed that doesn't move with a slip knot or a quick release knot. That's going to be really important. Okay, and so once this patient does not display the behaviors that warranted the restraints in the first place, like trying to pull out their IV, trying to pull out their NG tube, once they're no longer displaying that behavior, then we can contact the provider or the charge nurse, or if you're, a student nurse at a clinical site, you will and let your clinical instructor know, let the bedside nurse know, but whoever the next person is in your chain of command, you will let them know. And so then the doctor will write an order to discontinue that restraint. Okay. But as long as they're displaying those behaviors that require them to have it, then they need to keep that restraint in because it's going to be, keeping them safe. Okay. All right, so I'm going to stop sharing my screen. I'm going to ask you all, what is the definition of a sentinel event? If you know what a sentinel event is. A
What
sentinel event.
when a patient gets sent out to the emergency room or life-threatening?
Okay, yes. So, yep, you're definitely on the right track, right? And so a sentinel event is an event that can cause death or serious injury to the patient. Okay, and so it could be maybe the wrong medication was given, or the medication that was meant for Mrs. Jones is given to Mrs. Brown, right? But there's something that happens. Recently, I had a friend that had surgery on her spine, and she had a lot of external fixation keeping her spine in place. Then her husband sent me a message saying that they dropped her on her spine. And when I read that, I winced and I'm like, oh my gosh, that's horrible. So God forbid, say that, okay, they dropped her on her spine. She ended up becoming paralyzed or even, had a loss of life. That would be considered a sentinel event. Okay, so that's pretty serious kind of event. Okay, when we think about the patient, possibly having serious injury or even death. Okay, so that is a sentinel event. All right, so let's talk about our patient that is a CVA survivor, a patient that has had a CVA. What can you all tell me, if anything, about CVA?
I'm sorry, Miss San Ignacio. I think I'm here too early. I don't even think this is my class.
No, it's not, but you're welcome to stay. I was just going to type you a message. We're going to be starting in the next hour. We're going to start at 6.
Yes, ma'am. I'll be right back because I'm at work actually running back and forth. So
Okay.
I'll be back at 6. Yes,
Okay.
ma'am.
All right. Thank you. Okay. Um, so let's see, when we think about a CVA, so that is a cerebrovascular accident. Okay. And what do you all know about CVA, if anything? Let's see. And I'm going to pull up my slide for CVA.
So we're talking about so like CVA, you just like you don't really oh, I don't know. I was gonna say not move.
Okay, well, let's just talk about CVA in general. So the cerebrovascular attack. So what is actually going on with this patient when we think about CVA?
They had a stroke.
Okay, yes, they had a
Right.
stroke. So that's great. So The stroke is affecting one part of their body. Okay, it's let me just see. Okay, so when we think about a patient that's having a stroke, uh, we think about the brain, right? Because when you think brain, you should think nervous system, you should think neurological system. So the right side of your brain controls the left side of your body. And so when we think about that, if your patient has a right brain stroke, the left side of their body is going to be affected. If the patient has a left brain stroke, then the right side of their body is going to be affected. Okay, so if I am performing hygiene care for this patient, well, I need to make sure that I'm keeping them safe. And if this patient is a right brain stroke, I know that they're going to have the left side of their body that's going to be weak. Okay. And so what you mentioned before, Lakeisha, is about this patient and keeping them safe. And, you know, it doesn't even matter if it's a CVA patient. If it's just a patient in general, we're going to make sure that we keep the side rails up to keep the patient safe. So when we roll them, they don't roll right out of the bed, right? And so if we have a patient that has some kind of paralysis, when we are performing a bed bath or any hygiene care, we want to position that patient in the supine position, and the bed rails, both side rails, need to be raised. Okay, that's going to be important for their safety. And again, so they don't roll right out of the bed. Okay. All right. So what do you do if you have a situation where patients are complaining that they can't sleep because it's noisy at night? What would you do? Lakeisha, I'm going to ask you.
Like, cause they're close to the nurse's station and it's noisy, or just like
Yes,
another
they're
noisy.
just noisy in general. It could be close to the nurse's station, or they could be loud in the halls. Yeah, right. What would you do?
Um, I think I would could I move their room, or
That
they
that
shut
could be a possibility. That could be a possibility. Okay.
shut their door,
But what's even easier than that?
asking everybody to quiet down?
Yes, right. Asking everyone to quiet down, right? Sometimes I have to do that when we're testing and students are like in the hallways and they're just like, ah, I'm like, okay, there's testing here. So and they, you know, they didn't do it in a spiteful way. They just may not have realized that, whoa, there's testing going on right now. So the same thing applies to your, you know, your fellow nurses and your healthcare team. Okay, someone is trying to sleep right now, so keep it down, because sometimes we may not realize what we're doing and how it affects our patients. So that's all you need to do. Just request that your coworkers limit their hallway conversations. You know, they can go into the staff room where there's a closed door, because you want to make sure that your patients get the rest that they need so they can actually heal. Okay, so it's okay. You don't have to be mean about it. You can just say, okay, well, please keep it down, right? Okay, so that's going to be something that you can do. And really, usually the main cause of noise is just going to be those conversations. Okay. All right, let's talk about discharging a patient after surgery. So what are some of the things that we can do, or things that we should teach our patient once they are discharged and they're going home after, let's say, a hip surgery? Anyone can answer. Yes, Lakeisha.
So you would teach them, to keep their legs straight and abducted, right?
Okay, yes.
Ab,
Yep, because they would
no
use that
rotating.
abductor wedge, right? Because we don't want them to extend their legs too far, and we don't want them to cross their legs. So, yep, you're right.
Right.
What about when this patient is bathing and when they you know, are going home and they have to take go to the bathroom or they're bathing, what are some of the things we could do to keep them safe after this hip surgery? Well, maybe at home they can have these grab bars, right? Maybe they can have the grab bars by the toilet in the bathtub. Maybe they can have one of those chairs, those shower chairs, so the patient will be safe. But really, the grab bars are going to be very helpful because they have something to hold on to. And so, if they have, limitations or joint impairment, they can hold on to those grab bars if they need to. That's going to be really important. Okay. All right. So let's continue. We're talking about basic skills right now. The med-surg review is going to start at 6, but you're more than welcome to stay, Linda. So,
Okay.
okay. So when we think about our diabetic patient with chronic peripheral vascular disease, okay, when we think about that, we think about this patient that has diabetes, they have chronic peripheral vascular disease. What comes to mind as far as caring for this patient, the diabetic patient with chronic peripheral vascular disease?
To me, what comes in mind is like ulcers and things like that because they're not getting good circulation, right? And
Yes.
also um like maybe steady gaits because of numbness in your legs and things like that because of the circulation's being affected.
Okay,
Um,
yes. So yeah, Lakeisha, you're 100% correct. If I have my diabetic patient, if I have a patient that has peripheral vascular disease, I know that they're not getting adequate circulation to their lower extremities. I know that they may have peripheral neuropathy, so they may have numbness and tinglings in their fingers and their toes. They may end up with edema, and it may be unsafe for them to walk, or they will be unsteady. I also know that this patient is not a patient that I'm going to give a heating pad or an electric blanket to. I'm not going to give them a hot shower because they may not feel if they're getting burned, right? So these are all safety things to keep in mind for your diabetic patient. Also, if they have, chronic peripheral vascular disease. So extra blankets will be good for this patient. And bed socks, they can use socks, but not like electric socks or electric blanket or anything like that, because that will help them to stay warm. Okay, but please do not give your diabetic patients any electric blankets, okay, because they definitely can get burned. Okay, so if you have an agitated patient and they're jumping out of bed, um, do you think it's a good idea to raise all four side rails to prevent them from jumping out of bed?
off no, because that's a restraint.
It is a restraint, absolutely. So a better thing to do with this patient is to probably put them close to the nurse's station so that they could be watched. So this is one that a patient that, if they're agitated, they're climbing out of bed, I would definitely put them by the nurse's station. And you probably have seen them if you work in a hospital setting or even at clinical. It's like, okay, the bed alarm goes off, the chair alarm goes off, and everybody goes running, right? So we know that the side rails won't prevent them from falling, but if we bring them by the nurse's station or put them in a room by the nurse's station, we can keep a closer eye on them and we can check on them frequently. And that's really, really important. Okay. Now, sometimes we can have a family member or friend sit with the patient. That's a good thing too. However, that still does not relieve the nursing staff of the responsibility of making sure that the patient doesn't fall. Okay. So just because family is there, that doesn't mean, oh, well, their mother was there or their sister. Well, we still have to be responsible. So when that alarm goes off, we still have to respond. Okay, but we cannot restrain this patient in a physical way or a chemical way. But of having someone sit with them is going to be another way to keep them safe. Okay. If you have a patient that is confused, and they're threatening to walk out of the facility, what are some of the things you can do to keep this patient safe?
You can you can try to redirect them to
Okay,
ask what's going on and what's making them frustrated.
okay, yes. I love that.
Okay.
I love that. So you can definitely redirect them, but you don't want to leave this patient alone, right? Because you kind of want to understand what is causing them to be confused, what is causing them to be upset, and you don't want them to just walk out the door. So this is a patient that we need to stay with and try to find out what's going on. Why are they upset? Why do they want to leave the facility? Maybe something happened, and so we really need to get to the bottom of it. Okay, so let's talk about okay, well let's talk about SDS sheets. Any SDS sheets? Do you know what those are? Anyone? So the SDS sheets are safety data sheets. They used to be known as MSDS sheets. And so these safety data sheets, they're required by OSHA. And so they tell you, okay, if you get a certain, chemical in your eye, what should you do? Should you go to the eye wash station for 15 minutes, put a cold compress on it, right? And so we need to know per OSHA guidelines where these SDS sheets. Usually in a hospital setting, the SDS sheets are kept like in a binder in the medication room. When I was working in the hospital, that's where they would be, or sometimes they can be at the nurse's station. But just remember that the SDS sheets were formerly known as MSDS sheets, which were material safety data sheets. And it tells you for every, hazardous kind of chemical or compound that is on your unit, what are the immediate actions that you need to take. Okay. Um, so as nurses, we need to know where those SDS sheets are, and we need to be able to comply with the guidelines that's presented in those SDS sheets. Okay. So when we think about a patient that has a chair alarm, we know that if this chair alarm goes off, even if it goes off, 10 times in an hour, we have to respond every single time. We have to respond promptly to this alarm because the patient may be in danger, right? And usually, if a patient has a chair alarm or a bed alarm, it's because they're a fall risk. Okay, so we really need to make sure that we respond promptly. Okay, let's talk about fire safety. Okay, so can anybody remind me of what RACE stands for when we think about fire safety? Okay, there's two that we need to know. I'm going to share my screen. It's race and pass when we think about fire safety. As nurses, and I know at my class on Friday night, we had the discussion, what would we do if we had a patient, if we had patients and it was like a fire or something, would we abandon them and what would we really do? And I was like, well, nobody knows what they would actually do if unless they were in that situation, but I would like to think that I would try to safeguard the lives of my patients, because that's what we're supposed to do. So let's kind of talk about race for a second. When you think about, a fire or some kind of explosion or something that's happening in your healthcare setting, RACE is the acronym that we use. So rescue anyone that is in the immediate vicinity of the danger of the fire. Then we're going to sound the alarm so everyone else knows that, okay, there is a fire in the break room, or wherever it is, right? We may have to call 911 depending on what kind of facility we are in. We want to contain the fire by closing the doors. A lot of facilities will have double doors. Close the patient's rooms, the doors to their rooms, to keep the fire from spreading, because we know that that's just good fire safety, right? Because if there's an open area, that fire will spread very quickly. And then E is extinguish, okay? Extinguish the fire if we can. And I think in class we may have mentioned evacuate, but the E is going to be for extinguishing that fire. Okay, and then if we do have to evacuate, that's a whole nother set of things to think about, because if we have patients on life support and they need like ventilators, we have to figure out how we're going to keep those patients alive. If they're on oxygen, how we're going to keep them alive. Okay. So when we are extinguishing the fire, there is an acronym that you do need to remember, and it's called PASS, P-A-S-S. So if we are going to operate this fire extinguisher, we need to pull the pin. Okay, we need to pull the pin. We're going to aim at the base of the fire, and we're going to squeeze, and then we are going to sweep from side to side, from left to right, as we are trying to extinguish that fire. So when we think about fire safety, keeping the patient safe, we're going to use RACE and we're going to use PASS. That's going to be really important. Any questions about that? All right, so remember RACE and remember PASS, and you're going to be hopefully good to go. All right, the next thing we're talking about is a patient that has respiratory congestion. If a patient has respiratory congestion, what are some of the nursing interventions that we can apply for this patient? And I'm stop sharing right now because we're going to a different topic. Respiratory congestion. Anybody have any ideas?
You mean like I'm thinking like you mean treatment wise?
Yes, just anything. Just anything. What comes to mind?
Making sure that they got proper oxygen.
Yes, okay. So that's great, Tonya. When you say proper oxygen, what do you mean for this respiratory congestion?
Okay, so like for respiratory, like COPDs and stuff, like they sometimes get like a couple of liters of oxygen, just regular for them to breathe, as well as they might get like asthma pumps and things like that. So when I think about a person having a hard time breathing, they usually be on like some type of oxygen.
Okay, yes, and you're 100% correct. If the patient has difficulty breathing, they're going to be on oxygen. And you will see in our healthcare settings, a lot of the times those patients will be on humidified oxygen, because without that humidification, that oxygen can dry their respiratory passages, which can cause cracking and breakdown, and then increased risk of infection. So if your patient, is having respiratory congestion, one of the nursing interventions would be is to administer the humidified oxygen, and another intervention would be is to push fluids, because pushing fluids would allow those secretions to become less viscous or less thick. Okay. So that's going to be really important when we think about a patient with respiratory congestion. Give them the oxygen that is humidified, push fluids to help decrease the tenacity or the thickness of those secretions. Okay. Now, the next thing I'm going to ask you about is if you were transferring a patient and they are weak, and you have to transfer them from the bed to the wheelchair, how would you do this?
You could use a belt.
Okay, absolutely. So using a gate belt, that's a great idea. Okay, awesome. And I would make sure that the bed is locked, the wheels of the bed are locked, the wheels of the wheelchair are locked. Use that gate belt. And I would really seat the client on the side of the bed, right, with their feet touching the floor, because at that point, once we do that, all they're going to have to do is pivot and get into that wheelchair. right? So that's going to be really important. So and when we pivot the patient, we have to remember that we want the chair at a right angle. Okay, and use that gait belt, put the patient standing position, and we just have them pivot. Okay, that's going to be really important. Okay, so let's talk about now, let's see, how we would position a patient that is confused and we want to remove pressure over their sacrum. How would we position this patient? Any ideas?
Can you say it one more time? I'm sorry. My son is.
That's okay. So if you have a patient that needs to have the pressure taken off of their sacrum and they don't want to remain in a side lying position, how else can you position them?
You can put a donut under them.
Okay, yeah, so that's true. You can use that kind of a specialized pillow, right? So that's one way to position them.
Um,
Okay, can we place this patient in the prone position?
But then you say you have like dementia or something?
Um, So they're like semi-conscious. They're not necessarily dementia, but
Oh,
they just won't stay in on a side lying position. So can we put them in the prone position?
I believe so.
Yes, and you're right.
Yeah.
You're right, because that's going to take the pressure off of their sacrum. And because we know the big concern here is that they're developing a pressure ulcer on their sacrum. So we want that patient to really, get the pressure off. And if they won't stay on their side, we don't have much of a choice. And the prone position is a great position. And we will just support them possibly with a small pillow under their diaphragm just to make sure that they're still able to breathe, right? Because that's going to be one of the things that, okay, if the patient is in the prone position, can they still breathe? Okay, so, but yep, you're definitely right, Tonya. Okay, so what, what is the Sims? Okay. Okay, just please stay on mute. Okay, so what is the Sims position or the lateral lying position? Do we know what that, does anybody know what that is? Okay, I'm going to bring up a picture. The Sims position. Okay, so when we think of the Sims position, this is the Sims position. Okay, and so when we're working with the patient that is on the Sims position or the lateral lying position, we really want to raise the bed to waist level. We want to be at a good working height because we want to be safe as we are working with this patient. We don't want to hurt our backs. That goes along with, proper body ergonomics, right? So if you have your patient in this Sims position or lateral lying position, we really want to raise the bed to a good working height. Okay, and we want to utilize proper body alignment for this patient as well. So you see that we have the pillows supporting the head, the arm, the knee, and even there's a roll supporting the foot to make sure that the patient decreases the risk of foot drop. Okay, speaking of foot drop, what is foot drop? Can anybody tell me what foot drop is?
Yeah. It's just
When
like
you're,
what it said. Oh,
go ahead. Go ahead. It's when your foot points like a ballerina.
Yes, very good. Okay, so you're right, Erica. So let me bring a picture of foot drop. So what would you do to prevent your patient? Oh, that didn't come out good. Here we go. So what would you do? What are some nursing interventions to help your patient not get foot drop?
That foot roll do help. I think they usually have they like in like that little soft padding that keeps their foot count like up and not falling forward. Their foot needs some type of support.
Yeah, they
Okay.
place it at the footrest. So normally they place their foot right against the footrest. So it's
Okay, yes, you're absolutely right. Tonya and Lakeisha are right. And so we would use the footboard. We would use a roll. We can use high top sneakers, a footboard. So these are the different things that we can do to keep that foot from actually being in the position where the patient would end up with foot drop. Okay, because if your patient ends up with foot drop, then that is going to compromise their ability to ambulate, right, and cause further complications, which we don't want for our patients. Okay, we definitely don't want that for our patients. Okay, all right, so that is footboard. Sometimes also they may have Prevalon boots. Have you all seen Prevalon boots before? Prevalon boots, and I think we talked about the Prevalon boots. I think actually Daphne was the one that mentioned her patient having these Prevalon boots. And so let me just make sure everybody knows what the Prevalon boots looks like. So this is a Prevalon boot, and that would also not only help preventing foot drop, but it would take the pressure off the heels of our patient. Okay, so that's going to be important. Now, if you have this patient that has been in bed for a week after they've been on bed rest, the big thing that we want to look out for is orthostatic hypotension. We want to make sure that their blood pressure doesn't drop when they go from lying to sitting to standing. So we would have the patient dangle. We would assess the patient every time they change their position. And we would also make sure that we are assessing the gait. Now for the RN, they're going to be the one that does the initial assessment, but the LPN is going to then do the follow-up with that patient, because the RN is going to say, okay, this patient is steady on their feet, they're ×1 assist or ×2 assist, and so we will go from there. And so then the LPN will follow up with this patient after the RN makes that initial kind of assessment. Okay, now the UAP working with this kind of patient, this UAP knows that if she or he has to pull the client up in bed, that they will use a transfer device if they have to pull them up in bed before they, help this patient out of bed. Okay. But again, that transfer device must be used because we don't want friction, we don't want shearing, because that could compromise the skin integrity. Okay. So let me ask this group, because we have a great group, right, of motivated nursing students here. Why do we perform range of motion exercises on our patient?
Circulation.
Okay, very good circulation. That's true.
Keep the muscle from stiffening.
Yes, that's perfect, right? We want to prevent contractures in our patients. So that's why we do passive range of motion. So when we think about passive range of motion, that means we're doing the exercise for the patient. And active range of motion, the patient is actually able to do the exercise on their own. Okay, so range of motion is super important. It promotes circulation. It prevents contractures in our patient. That's really, really important. Okay. What do you do if you're moving a patient and they become dizzy? They say, okay, I can't stand up. How would you handle that situation? They're already kind of standing and you're getting ready to ambulate them and they say, oh, I feel dizzy.
Sit them back down.
Okay, yes. So you will sit them back down, right? So you'll step behind them, you'll grasp them around the waist or the chest. Hopefully you were smart and you did the right thing and had a gait belt, and then you will ease them down and slide them down onto the floor, gently onto the floor. Okay? Very good. All right. So, let me see. All right. Let's see. There's just a few more things. We're going to be wrapping up the PNR 104 section in just a minute. So when we think about bed positions. Okay. Okay, so Daphne says she has a client who has to have one on her at all times. Yeah, because she's probably a high fall risk, Daphne. Is that true? Yeah, she probably is. Okay, so somebody tell me, what is the mid Fowler's position? What's the degrees that we're talking about here for the patient? Mid Fowler's.
That's 45.
45 is in the range, so you're right. Okay, so it is in the range, so you're right. Okay, so 30 to 60 degrees, okay, is going to be that. And so you're right, Tonya, that 45 degrees, okay? And so this Fowler's position, you know, we're elevating the head. The high Fowler's position is going to be 90 degrees, okay? So, and tell me, why would we elevate the head of the patient's bed? Give me some examples of why we would need to do that.
It helps them when they're trying to breathe.
Yes, absolutely. It helps them if they're trying to breathe. And we know that patients that are on feeding tubes, they should never be in the supine position. They should be at least in the semi-Fowler's position, which is elevated, the head of the bed elevated 30 to 60 degrees. So yes, 90 degrees we don't use on a day-to-day basis. But if the patient is eating, if the patient is having respiratory distress, we want them in that high Fowler's position because that's going to help them with their current situation. So, yep, and Kayshelia says breathing. So, absolutely, absolutely. So if we have, this is another scenario, we have a patient that is immobilized, they have right-sided weakness, they just had a stroke. Okay, what would we do in order to help move this patient up in bed? What are some of the nursing things that we would do? This right-sided weakness patient, they just had a stroke, and they weigh about 250 pounds. What will we do?
We need a pull sheet.
Okay, yep. So we definitely need a draw sheet to help that lift sheet. Okay.
Two
Keisha is
person, two
two.
person, and put them in transfer position and kind of hopefully have the gravity help you while you pull them.
Okay, yes, as long as it's not contraindicated, right? So yes, absolutely. So you all are saying great things. Get that draw sheet, get a lift sheet, get some kind of device that's going to help reduce the friction and help move that patient. Get at least one other person. This is at a minimum a two-person assist, okay? And lay the client flat on their back as long as they can tolerate it, right? You don't want the head of the bed elevated for this turning or moving of this patient because it's going to be really difficult to do that. Okay, we don't want the bed in the semi-Fowler's position. We want them in a supine position. Now, sometimes in real life, this is going to be challenging because if that patient has difficulty breathing, right? So you kind of have to look at the situation as it's presented to you. Okay, and if the patient is able to help, then that's great. But if they're not able to help, make sure that you have enough help there. Okay. All right. Let's talk about infection. Okay, infection. So the patients can have infection and they could be having a local infection or a systemic infection. Can anybody tell me the difference between a systemic or local infection?
Like I know the difference. Like a local infection could be like a bite or something that's like just like one area. I think cellulitis can be like that too, like to one area. But when it's the whole system, it's like the flu. It's like it's like one of them ones that affect the whole body.
Okay, yes, you're absolutely correct, right? And so, yes, cellulitis could be a localized infection. It might be cellulitis of the left lower extremity. And remember, cellulitis does spread very quickly. But when we think about systemic infection, now it's in their bloodstream, it's throughout their body. And so if there's a localized or infection, maybe that area is going to be red and warm to touch. But if it's a systemic infection, that patient's going to present with a fever, right? And so we know that we can become infected with pathogens, and pathogens can be bacteria, viruses, parasites, even protozoas, right? I was just reading an article about brain-eating amoebas, right? So these are the things that infect us, that can infect our patients, these pathogens, okay? But yes, understand the difference between systemic and localized infection, okay? Do we have to give our geriatric patients a bath every day?
No,
Okay, and how come? How come they don't need a bath every day?
they lose heat, so that bath kind of, to my understanding, kind of like, it makes them, first of all, it makes them dry, and so their skin integrity isn't that great. And then them taking a bath every day, like I said, I think them losing of that body heat sometimes too cannot be good for them. Um,
Absolutely. Yeah, so that's perfect. So they don't have to take a bath or a shower every day. So at least twice a week, and they may need assistance. And so they will, as geriatric patients, they have decreased sweat and sebaceous gland activity. So they don't need that full bath. And yes, their skin can become dry, and that will increase their risk for skin breakdown. So just assist your geriatric patient to the shower or the tub, just probably about twice a week. Okay. All right, excellent. So as we're talking about hygiene, something to keep in mind is that your patients and you may not have the same concept of hygiene. We may not share the same hygiene practices. So we want to take into account that different cultures may have different views of hygiene, and we want to respect the client's wishes, okay? Just something I saw, Keishalia mentioned log rolling. Log rolling is going to be a good thing to do for your patient if we need to keep the spine in alignment. So that could be like your spinal patient, like my friend that had that surgery, that they should have been log rolling her, but they dropped her instead. So let me see, but that keeps the spine in alignment, and we really need at least a couple people to do that when we are log rolling a patient, okay? So in this picture, it shows you in a perfect world, 3 people. So one is covering the head and the shoulders, one is covering the torso, the midsection, and then one is covering the legs, okay, when we log roll a patient. And you see here, this patient has a collar on to stabilize the C-spine. Okay, so that's I just wanted to mention that because Keishalia put that in the chat. So thank you for that. All right. Just remember your differences in your pressure ulcers, and who can tell me how we care for a patient's dentures?
You put a washcloth in the sink whenever you're cleaning them.
Okay, yes, excellent, right? And so as we're cleaning the dentures, we're brushing the dentures just like we would brush the teeth. We put them into a container with the patient's patient label on it. Sometimes they may use an effervescent tablet. And remember, when you clean the dentures, you also have to provide mouth care. Okay, that's going to be important. But when we remove and clean those dentures, we store them in a label container at bedtime. Now, sometimes your patients may want to sleep with their dentures, so you have to respect their wishes. But if they do want to take them out at bedtime, make sure they're in a sealed container and label. Okay. All right. If your patient is at risk for pressure ulcer, should I place my patient directly on the trochanter of the femur? No, Daphne says no, absolutely not. We know that taking the pressure off of these bony prominences is going to be the way to go. All right, I'm going to stop recording.